So I want to introduce Dr. Christian Streck. And Chris is the Division Chief or Surgeon in Chief?
Division Chief.
Division Chief of Pediatric Surgery at MUSC, Medical University of South Carolina. And he has had a fantastic publication on the role of CT scan in blunt abdominal trauma, and we really liked his work and his paper, and we invited him here to really give us some information about what we need to know now, how times are changing with CT for blunt abdominal trauma. Chris, thanks for doing this.
Sure, thank you, and thanks for the panel. I feel a little that Dr. Ponsky set me up here because he let David go first, and David presented a really interesting case of a hemodynamically unstable patient. And I'm going to spend my time talking about the 97% of the patients that we see following blunt trauma that are hemodynamically stable. So it's not quite as glamorous or exciting, but these are the patients that typically come into a pediatric trauma center. And I cheated a little bit. I have two cases, but they're from the same vehicle, and I wanted to use them to kind of make the point about who might benefit from a CT and who we can avoid it from. So the first is a 6-year-old male. He was a restrained backseat passenger in a motor vehicle collision. It was reported as a car versus a tree head-on at a high speed. He was on the passenger side in the back seat. There was no known loss of consciousness, and he presented hemodynamically stable en route. In our center, we have a tiered trauma activation system, so he was the second highest level. On primary survey, he had a patent airway. His respiratory rate was 27, blood pressure 111 over 81, heart rate 131. On Broslow, he was about 20 kilograms and had a GCS of 15. Pertinent physical exam findings, he had some mild midline cervical spine tenderness to palpation, and he had a noticeable seatbelt contusion. I'll show you a picture of that. His abdomen was fairly soft, a little bit distended, but there were no obvious peritoneal signs. And he had the following imaging finding, which is this contusion here on the abdomen, consistent with a lap belt type of mechanism of injury. The second patient was his sister, also in the same vehicle. She's, sorry, I went the wrong direction. She is an 11-year-old female, also a restrained backseat passenger in the vehicle. She was found slumped under the front driver's seat. There was a reported loss of consciousness. She was hemodynamically stable en route as well. Again, a level B activation in the adjacent room. ABCs were pretty unremarkable. She also had some mild midline cervical spine tenderness, and she was very distracted. She had several fractured incisors, a lip laceration. Her midface was stable. And on physical examination, although she was very distracted, she seemed to have a normal abdominal exam. She did complain that she had some mild abdominal pain.
Yeah, I think I'd like to point out for our audience that the seatbelt side or the abdominal contusion really should be a red flag for everyone. So a lot of surgeons may not see that very often, but it really means that there's a tremendous amount of force that's been generated against the patient, and so you really need to be vigilant that that child does not have an underlying abdominal injury.
Sure.
And sometimes it's very difficult to assess a bowel injury on CT scan with that. You can assess the abdominal injury, but the bowel injury is difficult to assess.
Absolutely. So I picked these two cases because obviously the same mechanism of injury, and I think questions for the panel really is, what is the routine at your center? You know, the goal of a lot of the work we've done is to try to determine what population of patients don't benefit from abdominal CT. So who do you believe, if you will, in getting labs and plain films in the trauma bay? Does that depend on activation level? How would you have triaged this patient? And then ultimately, who is responsible at your center for determining what the evaluation is? Is that the ED physician? Is it the surgery resident? Is it the adult trauma surgeon that's at the bedside? Is it the pediatric surgeon? And we've had a lot of discussion about FAST this morning, and I share a lot of the same biases with the panel, and I have some data to share about FAST in our experience. But do any of you use FAST to try to avoid an abdominal CT, to try to find a patient population that you feel comfortable not scanning?
I would like to, but
No.
I don't.
I don't either. I think
Yeah.
the problem that we have is that it's not sensitive or specific, and I don't think it ever will be until we get IV contrast for it. And, once we have and we actually just got IV contrast for ultrasound, which may make a difference, but not right now.
And then how about the question about labs and plain films? Do you have a routine based on activation level, and what is your standard routine for labs and imaging?
We certainly have a routine. I can't quote off the top of my head what labs are at each level, but labs and x-rays are part of the initial evaluation.
So one of the things that I find interesting is we have different tiers of evaluation. The lowest tier is really only evaluated by the ED, and we've actually noticed that those patients get more labs.
Sure.
And sometimes more imaging, which I don't know if you guys experience the same things in your institutions.
That's a great point.
As well. So, it's interesting because I think that we try to tailor who's going to get imaging, because we are very sensitive to the CT scanning and radiation and everything that goes along with that. The flip side is that I think that in some ways we've gone almost too far, because it's sort of like with the non-operative management, right? You still need to be able to recognize when somebody needs to go to the operating room and you see people hanging on by their fingernails to try, like going to the OR as a failure or getting a CT scan as a failure. It can't be seen as a failure. You just need to know which patient it's appropriate in. But we do labs, and we base our scanning. If you have a patient that you can examine and their belly is soft and benign, and we do use the LFTs based on that old study from CHOP. And I can never remember which one the AST is supposed to be, which one the ALT is supposed to be. If either one's over 200, we scan them.
I'm going to clarify that.
I know you are. I know you are.
Yeah.
I did see ahead. So
Okay.
I'm sort of giving you a little
Yeah.
foreshadowing here.
Yeah.
But I do think that you can still treat the patient clinically, but we do have routines.
Okay. So a little bit more information about the two patients. So we rely a lot on labs and imaging to try to assess some of these hemodynamically stable patients that have a seemingly reliable physical exam. So the brother with the seatbelt contusion, hematocrit was 37, white count 21, AST was 49, his lipase was normal. We didn't order a base deficit or lactate, and he had a normal chest x-ray. In contrast, the sister had an elevated AST. Her AST was 222, and she had some small pulmonary contusions on her chest x-ray. So this really gets to the heart of the matter. Who needs an abdominal CT? We kind of spoke about FAST, and I'll give some data on that. And looking at the first patient, is there time or a benefit to imaging a hemodynamically stable patient with abdominal tenderness and a seatbelt contusion? Looking at the second patient, is there any benefit to getting the screening labs to see if this is a patient potentially who could avoid a CT of the abdomen altogether? And then this is not one of the cases I presented, but what about the patient who comes in intubated that has a serious mechanism like a MVC or ATV collision, but has a normal physical exam on your evaluation? So what do you guys think on these two patients, or the three examples? Who of these patients would you get an abdominal CT on?
I agree with Whit 100% on the seatbelt sign, and abdominal tenderness and a seatbelt sign. I would be very, very concerned about that.
And I'll tell you, the seatbelt sign that you showed is a really bad seatbelt sign because it's not in the right place.
Yeah, well, that's
exactly
the
right.
key.
Wanted to point.
That's always the question, because we sometimes will watch a seatbelt sign. If it's over the anterior superior iliac spine in the right place, it may just be a little, and you can follow the patient. Because first of all, CT scan's not going to be super sensitive for picking up the injuries, although our radiologists, I think, are pretty good at it. They'll see the focal ilius or something. But I really think that if it's in the wrong place, then you're...
Can you go back to the image and just point out,
That image, while you're going to find it,
it's a great image, by the
is
way.
why.
Yeah.
That's what all my kids' seatbelt sign would look like, because every time I look back, they got the lap belt.
The head is up here, and here is the umbilicus. So this is closer to the costal margin here.
And you want your seatbelt sign over the bony pelvis. That's the way it's designed. That's why we have booster seats.
Sure. Absolutely. Would anybody have gone straight to the OR based on a seatbelt contusion alone?
No.
Okay. So I'm going to give a
Both
little bit.
patients are stable, though.
Both patients are
stable.
stable. And as I said, 97% of the patients in our study that I'm going to mention were normotensive. So hopefully this will project, but this patient, if I can get the pointer to work, there's some free fluid that's intermediate density along the liver here. This is the posterior wall of the stomach. There's fluid in the lesser sac, maybe a couple dots in free air in the next cut. The duodenum seems to have a hematoma here, and there's some paracolic fluid in this gutter as well. This is just another cut of the same image showing the same findings. Our radiologist interpretation of this, other than what I've mentioned, is that this patient, in their opinion, likely had a posterior gastric wall injury. I can agree with this, but certainly the findings were highly suggestive of a hollow viscous injury. And then the second patient, we did scan based on her elevated AST, and she had a normal abdominal CT.
Well, I feel better because I would have scanned both patients.
Okay.
So.
Yeah, that's what I was going to say.
I'm glad you scanned both patients.
Okay. All right, so I'm going to present and try to keep it to 5 or 6 minutes, some of the data that we've put together to help drive decision-making about abdominal CT. One of the things that's been most successful is we have a group, the Pediatric Surgery Research Collaborative. Several of the moderators here have contributed faculty members to this group. We have 14 institutions that have participated in the data collection, and mostly just want to thank all of them. Obviously, this is an important topic. There's a lot of pressure, I think, now in the trauma world to get abdominal CT. And this is despite a low incidence of intra-abdominal injury. Less than 12% of the patients have an injury on CT. There's associated cost. Of course, we worry about radiation-induced malignancy. In contrast, 90% of these patients that are pediatric patients come into a non-pediatric center. And standard at most adult trauma centers or non-trauma centers is to pan CT. There's actually a lot of literature out there on adult patients that suggests pan CT is safer, there are fewer missed injuries, it's more cost effective. So this is essentially what we're up against as pediatric providers, is that the pressure is in the kind of the other direction. There are a lot of studies in the past that have tried to identify some combination of mechanism, history and physical exam findings, labs, that might allow you to identify a population where you don't need to scan the patient. And that was really the goal of our study, was to come up with a prediction model that was very impactful. In 2012, David mentioned the PCARN group. They put together a prospective study, and their primary outcome variable were patients with an intra-abdominal injury that required an acute intervention. So they wanted to find or identify early patients that needed urgent surgery, that might benefit from angio, that needed a transfusion. They had a criterion of admission for 48 hours for IV fluids. To me, that's not really an acute intervention, but it is a type of intervention. And they only used history and physical exam findings. This is a bit challenging as the providers doing this. There's a lot of subjectivity to just using history and physical exam. We actually validated their model, and what we found was that it was actually very, very sensitive for injuries requiring acute intervention, but it missed a lot of clinically relevant injuries, mostly solid organ injuries like liver and spleen injuries, which we felt were important because it affects how we manage the patient, even if we're not rushing straight to the operating room. So our goal was to come up with a prediction model. We also limited our model to patients that were within 6 hours of injury, that had not had a CT scan prior to transfer. These were patients that didn't have a focal injury to the head. These were truly blunt abdominal trauma patients. And we did a lot of fancy statistics. You can look at the paper if you're interested, that's in Journal of the American College of Surgery this year. But we came up with a prediction model. These truly were patients that you would say had a severe mechanism of injury. Almost half were motor vehicle collisions at greater than 30 miles an hour. pedestrian or bicycle versus automobile, ATV accidents. And what we found was very consistent with prior studies. Only about 12% of the patients had an intra-abdominal injury, and fewer than 3%, even when we selected for more likely injured patients, had an injury requiring acute intervention. And most impressively, I think, was this, that the range between the 14 centers of CT scan ordering ranged from 4% of the population to 96%. So that shows you, I think, that there's a great opportunity for improvement in how we decide who needs a scan. These 5 variables, this is really the take-home point, I think, are the variables that came out in the prediction model: AST greater than 200, an abnormal physical exam, an abnormal chest x-ray in the bay, a patient complaining of abdominal pain, or an elevated amylase or lipase. This identified a population that had a 0.6% risk of an intra-abdominal injury and a 0% risk of an injury requiring acute intervention. So at least a third of the patients that we're seeing, potentially more, don't need a CT scan even when we select for a more injured population. So negative predictive value was 100% for the injury requiring intervention and 99.4% for all injuries.
So does that mean if you had all 5 of those were negative?
Correct.
But if you had one of those 5, you're not in that group?
You're not in the very low risk population. So, and I'll show you kind of a breakdown of that. That's an excellent point, Dr. Holcomb. So this is looking at the patients by number of abnormal variables, whether they had an injury like a solid organ injury most commonly, or an injury requiring intervention, most commonly hollow viscus. And as you went up in the number of variables that were abnormal, this was the risk of an injury or an injury requiring intervention based on the number of positive abnormal variables. And those are the confidence intervals that were associated with that.
So if you had 0 of those, there was no patient who had an injury?
That required intervention.
That required intervention.
Okay,
that's right. And there were only 5 that had an injury at all. They were mostly more minor solid organ injuries. So to make it a little more clinically practical, we reordered the 5 variables in the order of information that you obtain as the physician. So the patient complaining of abdominal pain, if it's no or you can't assess based on being intubated or sedated. The next was the physical exam of the abdomen, chest x-ray, AST, and abnormal enzymes. You still have the same 34% of the population, but if you wanted to look at a group that you might be able to observe or send home with careful instructions, what we found was a low-risk group that made up 55% of the population with a less than 5% risk of any injury and a less than 0.3% risk of an injury requiring acute intervention. One of the things that has been criticized about this type of model is people don't feel like they can wait for labs to come back. And I think this would suggest that you certainly can wait, even if it takes an hour to get your AST or your lipase. These are patients that, if stable and have a reliable exam, that you can kind of park in the pediatric emergency department and wait for your labs to come back before you make a decision on abdominal CT. And we certainly send patients for a head CT sometimes without getting an abdominal CT.
So the challenge from that are 2. One is that you occupy the emergency room bay for an hour while you wait for labs, and we've done a lot of work to try to minimize the amount of time that patients spend in the trauma bay. And then the second is if you send them for a head CT and then the labs come back positive, you have to send them back to the CT scan.
Our scanner is immediately next to the ER, and we typically move them out of the trauma bay to a standard ER room to avoid tying that up. In my opinion, saving the radiation and the cost of the CT is probably worth, an hour of time. But I think, as was mentioned earlier, it depends on your local resources, your comfort level, how busy your ED is, and
I'm sorry to keep jumping in, but the other issue that always comes up is the radiation exposure issue, and I think that sometimes that's more emotional than it is fact.
Sure.
We don't know what the risk of malignancy is. And
defer that discussion because we have an entire talk about that coming up next. So we'll defer that because I want to get Chris go on. And I want to apologize to the virtual audience because they are lighting up with questions and,
Okay.
and we have not had time to get to them.
Sure.
I want to not discourage anyone. Please keep putting them because Chris will answer these, David will answer these, Mike, if it's a radiologist, we will answer these questions. I want to do what we call rapid fire here. Not much discussion, just a quick answer. Question is from, and this is coming from Khalid Sharif. He says, in a patient that has a seatbelt injury, they believe he should get oral contrast. It's the only way to rule out a perforation. That's the first question. Quick answer.
I would say I disagree. I agree that it can be difficult to identify patients with small bowel or colonic injuries. I don't think oral contrast adds to that. I think our CT scans have gotten so good with the multi-slice scanners that typically there's evidence, it may not be free air, but there are subtle findings that would make you concerned for small bowel or other hollow viscous injury.
Okay.
There's also time, I think. The data has shown that there's time to do serial abdominal exams on patients.
Yeah.
And even if it's not clear on the CT, you may determine the patient needs further evaluation based on serial exams.
Mike, anything to add to that, or does that pretty much cover it?
I would agree with that.
Okay.
The thing is, though, also that a bowel injury, although it's an injury, is not a life-threatening
Correct.
problem.
Yeah. Okay.
And so even if you're unsure on, like that scan he showed, if you're unsure if there's an injury, observing them for 6 hours or 12 hours and reassessing them, there's nothing wrong with that. You don't want to observe them for 5 days, but observing them for a few hours is a good way to be sure, if you will, that they need an operation.
Real quick, no, am I wrong to say this statement? A missed bowel injury, if caught within 24 hours, usually has no increased morbidity. Is that a false statement?
There is a study through ABSA a few years ago that supports that. Of course, I think the flip side of that is we don't want to have delays in diagnosis or missed injuries. I think in 2017, particularly in the patient that I showed, laparoscopy is extremely helpful. If there's even just a moderate amount of free fluid in a male and no hard signs of small bowel perforation, I certainly would consider laparoscopy in those patients. I think this is a different era than 20 years ago where patients went for DPL or immediately for a big laparotomy. We're pretty good at laparoscopy now, and it's very rare, in my opinion, that you would miss something doing a laparoscopic exploration.
Okay, and then those questions that they're answering for each other. So I appreciate you guys all answering each other's questions. Lipase versus amylase. I think the question was asked a while back about if we don't have lipase, is amylase good enough?
Yeah. So in our study, when we designed it, we allowed for either. And when it says abnormal pancreatic enzyme, it could be amylase or lipase. In our institution, they only do lipases. Most of the places, I shouldn't say most, it was pretty evenly distributed between getting an amylase or lipase. A few institutions got both. There is huge variability in the lab evaluation of these patients, and I think that was one of the most impressive findings, is that we are all over the board in how we use labs and which labs we choose to use to evaluate.
Great. All right, sorry to interrupt.
Yeah. I just have 2 slides left, and then if there's time, we could have more discussion. But basically, in conclusion, we came up with a prediction model. I think it's highly practical. Currently, we're validating this. The nice thing about the PCARN data set is it's publicly available. We just submitted an abstract that was accepted to EAST, and our negative predictive value of this model and their data set for all injuries was very significant. So I think this going forward, the challenge will be to get people to implement this and to see if this is better than current practice. So that is our goal moving forward. There are always questions about who to apply this to, and again, 97% of the patients are hemodynamically stable. There's a lot of variability amongst institutions, so we can certainly do better. I did want to just show real quick a couple of slides. We did a subset analysis on FAST, and that was one of the topics. So when we looked at FAST in these 2,188 patients, we compared FAST to CT in the patients that had both, which was 340 patients. And we found that FAST was very not sensitive. So it had a 27.8% sensitivity for injury and 44% for injury requiring intervention. So the negative predictive value was 76%, which you might say, well, that's not that bad. But if you really break down the data and you look at solid organ injuries, so there were 42 liver injuries. FAST picked up 9 and missed 33 liver injuries. So picked up about 1 in 4 liver injuries. That's probably because in kids you don't always get a whole lot of blood. You don't have a lot of hemoperitoneum always. Likewise for spleen, 30 injuries, 13 were positive, 17 negative. And when we looked at the interventions, again, of the 14 patients that got transfused, 5 had a positive FAST, 9 had negative. Hollow viscous injury, it picked up 7 of 15. And surgery, it picked up the 1 patient that required surgery. So again, to echo what Dr. Van Almen said, FAST may be very helpful in the hemodynamically unstable patient where you're trying to identify hemoperitoneum, you're not sure what cavity is contributing to your issues. And then the final one on FAST, this is looking at FAST and CT variability by the 14 centers. Starting from left to right, this is MUSC. We're center 1, we fasted everyone, and we scanned about 21%. As you go down and fast, there was not a direct correlation in CT. We're kind of all over the place on how many CTs we get. Interestingly, of the 14 centers, only 1 used a negative fast to reduce CT, and 2 centers actually did more CTs after fasting patients. So we're not using FAST effectively to determine which patients can successfully avoid a CT. So don't use FAST to give you a false sense of reassurance that you don't need to scan the patient, and that's kind of the scatter plot.
I think though, that's a reflection of who's doing the FAST.
Absolutely.
That generally speaking, it's being done in the emergency room by ED physicians and sometimes by the surgery residents or fellows, and yet they haven't gone through a 3-year fellowship in radiology or residency in radiology, so they are not as good as an ultrasonographer might be who's in the trauma bay. And so it'd really be interesting to see if you had a real well-trained ultrasonographer down there doing the FAST, if the results would be any different.
Yeah, I agree. This is more a criticism of how we do FAST than the technique itself. I will say what we learned in this study is that every single patient that had an intervention, whether it was a transfusion and the few that had an angio or an operation, had a CT scan first. So FAST really didn't change our management. These patients are mostly hemodynamically stable. Scans are really quick to obtain, and they often impact your clinical practice.
Yeah, I mean,
David, first of all, Sophia Abdulhai, the research fellow here in Akron, I'm going to task you, Sophia, after this course, to send out all the participants what we feel were the key main take-home point from what each of you are talking about. That's the key. And if you could, and also, Sophia, if we can post in the chat these articles that they're referencing, the articles that they've published, so everyone can have these links to the articles. Chris, give me the bullet point key take-home points that we now need to know that's new and different.
Yeah, the main take-home point is to review the clinical prediction model. 97% of the patients that present following blunt trauma are hemodynamically stable. These are patients that you have an opportunity to do a solid physical exam and history, get screening labs. In this case, we recommend an AST and a lipase or amylase, to get a plain film of the chest, and to identify a patient population that likely does not need an abdominal CT. This is what we would suggest as the best practice to avoid unnecessary abdominal CT. I think it also provides guidance to the 90% of providers out there that don't see children all the time, that are evaluating the kids in their ED, that they don't need to scan every patient before they call us about the patient. There are a lot of other injuries the patients have that they may benefit from pediatric evaluation. We're happy to just see these patients and transfer, and we can decide who needs a CT. There's certainly time. You don't have to rush everybody to the scanner.
Okay, that was great. Hold on, David, 1 second, and then I want to ask David Notrica 4 bullet points from what we've learned from Atomic. 4 points. Or 3.
Number 1, failure is can't be guided by an algorithm. You basically you fail when the surgeon says you fail. 40 per kilo is a good cutoff for failure. Shock index is great for letting you know who's not in shock. It may not be great for telling you who needs an intervention, but it will. But if your shock index is not elevated, you can relax pretty significantly. Last take-home point is I'll refer back to Streck, which is his prediction rule is only 5. PCARN was 7. His prediction rule is independent of GCS, and I think that the PCARN basically was only useful in kids who had
14 or 15.
14 or 15. And I think that really that is a great contribution to the literature. So I'll hand it to Chris for that.
This has been fantastic. David, did you have a last?
Two quick points.
Okay.
So one question I have is that we have a group that's the intra-abdominal injury identified. There's the intra-abdominal injury that requires intervention. I think there's a third group that's intra-abdominal injury that we just don't care about. We've seen over my generation, we've gone from prolonged hospitalization, multiple labs for a grade 2 liver lac, and we know that those kids probably could walk out of the hospital and probably without any. So my question is, first question is, can we find a third category where we don't really care? The second question, I care, but
We care about the kids.
Yes.
Yeah, we just don't care about the injury.
Right.
Okay.
And the second question is, we're all fortunate to be at kind of high-end institutions, and we're talking at whether it's PCARN, whether it's PEDS, SRC, Midwest Collaborative, FIS, but a tremendous amount of care is done at community hospitals, and we have to think about whether it's telemedicine, education, outreach to say help them. They don't have safety nets, they don't have rescue strategies for patients who fail, to make sure that these are applicable and can be generalizable.
What do you think about the question, are there solid organ injuries that we really don't care about?
All right, so there is a subset of solid organ injuries that we probably don't need to know about. When we find a grade 1 or a grade 2 injury, it's very, very unlikely that they are going to fail non-operative management for that injury. Now, they may fail non-operative management for a bowel injury or pancreatic injury, which is what we saw. And if you look at all the kids that fail, the failure rate of non-operative management of solid organ injuries is 7%. And everybody said, oh, it's 3%. Well, no, actually, if you define failure as a laparotomy, it's 7%. 3.5% of those patients are failing because of bowel injury or pancreas injury. 3.5% are failing for bleeding. The other thing is, if you have an isolated spleen, you are incredibly unlikely to fail. If you have an isolated liver injury, you're unlikely to fail. It's when you start getting patients who have both injuries that really your risk of failing goes up tremendously. And so, yes, there is a segment of injuries that we don't need to know about. We just haven't quite figured out what to do with that at this point.
All right, we're running way over in time, but Aaron Lipscar has a question or a comment.
One quick, I guess, question or comment just about the FAST scan, because we've talked a little bit about it, and from the senior mentors of pediatric surgery, heard a lot about fast hating and such. And we suffer in my institution of the same problem of low-level residents doing fast scans on every patient and pushing them out of the way so we could actually evaluate their trauma. But my problem with it is the FAST scan is another point-of-care ultrasound technique that we as surgeons, I think, we should do it, right? So instead of the low-level resident, if your fellow or your fourth-year general surgery resident or you or I learned how to take a probe and quickly put it and find out the information, then you would trust that. You're not going to trust the intern in the ED who's learning on your patient and doing a FAST very slowly. But it might be a very useful thing, and I always imagine the days that we as surgeons or doctors have ultrasound probes that connect to our phones and look for appendixes and take them out in trauma and gather the information that we as surgeons can help our assessment.
No, let me just address that. I think you're absolutely right. Whit has one set up at his institution. We have kind of a little different one at ours, and you have to do 50 ultrasounds to be qualified to do a fast at my institution, and it's not that hard if you're fasting patients who are hemodynamically stable. I think it's important that the surgeon do it, and I think that the reason that we should keep doing the fast ultrasound partly is so that you're good for the unstable patient, like you guys discussed. But I think that when contrast, IV contrast for ultrasound becomes commonplace, we're going to replace CT with ultrasound. I don't want to spoil it from the next talk. I'm hoping that that's what's coming next.
Yeah.
But I think that IV contrast for ultrasound is going to be revolutionary.
Actually, that's my cue.
Oh.
That was a great segue. Perfect.